Hello, welcome to episode 158 of the Inside Knowledge podcast. I'm Anna Mapson. Today, I'm joined by dietitian Chloe Hall, who is a specialist in Mast Cell Activation Syndrome, or MCAS, which is what we're going to talk about today, but a lot about gut health, histamine intolerance. She works a lot with long COVID and POTS, which is Postural Tachycardia Syndrome. She's got a lot of experience as well with connective tissues and Ehlers-Danlos Syndrome, which we spoke about last week with Alex Orphanides. Chloe is particularly passionate about MCAS. She is on the board for one of the charities. She's got a lot to say about it, and she also has some personal experience that she mentions in the podcast with her husband. So it's a really useful episode. The reason I wanted to bring this in is that MCAS is one of those syndromes or one of those areas of health where people have a lot of confusion. There's a lack of medical support and kind of clarity on where in the NHS should be dealing with this. So we'll cover that in the session. It's really interesting and helpful, and I think you're going to find it very useful. So let's go. Chloe, welcome to the Inside Knowledge podcast. Thanks for being here.
Thanks so much for having me.
Right, well, should we start off with maybe you can say a little bit about your practice and what kind of work you do?
Yeah, so I've been a dietitian for over 15 years, I think. You lose count after a while, don't you? But and I worked in the NHS for many years. And then my husband, we found out he had something called MCAS, which we'll talk about more today. And I became really interested in this world of like histamine, MCAS, all the complex chronic illnesses that people have that are really misunderstood. And not always that well supported. So I set up my private practice, the Calm Gut Dietitian, alongside my work in the NHS, but now I'm completely out of the NHS and run my own private practice, sort of supporting these people with these, I guess, lesser known illnesses.
Yeah, amazing. And have you had to do a lot of that investigation yourself in terms of like your training? Did you have a lot of this covered, or did you have to then go off and investigate how to do this when you wanted to specialize in it?
Yeah, no, absolutely not. So I trained like 2007. MCAS was only just had a name for it. So we weren't taught about any of it. I didn't know about histamine. It was actually something I stumbled across at work and texted my husband going, "Oh my goodness, this is all your symptoms." Like all the stuff that no doctors have been able to explain, like why all these things happen to all the different parts of your body. This kind of makes sense, and why you feel worse at the weekend when we've probably had like a fried breakfast full of processed meats and loads of chocolate and things that we wouldn't have during the week. So no, I didn't know about it at all. So I went away and did loads of research when we were looking into it for him. I've done extra courses like the allergy course through Southampton University, which touches on histamine and other food chemicals that can cause like allergy type symptoms. And then, I've gone away and done courses on things like Ehlers-Danlos Syndrome and things like that. But no, it's all been extra stuff that I've learned along the way, which has been really, really helpful. But I do feel that I probably missed loads of patients early in my practice that probably had these issues, and it'd be great to go back, wouldn't it? But it's good to know about it now, and hopefully more people will have awareness of these conditions going forward.
Yeah, definitely. And things like this, you being a spokesperson for them will be really helpful. So yeah, let's just explain. So what is MCAS for people who don't know about it?
Yeah, so MCAS is Mast Cell Activation Syndrome. We all have mast cells in our body. They're our defense system. So they act as our defense. They stop invaders coming in. So things like illnesses, they will release loads of chemicals that protect our body against those. And they will react if you had like a primary allergy, like a peanut allergy, for example. What happens in MCAS is those defenders become on high alert all the time. So they release a huge amount of chemicals that they don't usually do in reaction to triggers such as the environment or foods that people eat or temperature changes or stress. And people can get whole body symptoms. So it can affect literally every system of your body. So your gut. So people can get symptoms like bloating, pain, diarrhea, constipation, reflux. But you can also get other symptoms such as hives or brain fog, or things that affect your heart. So things like palpitations, or, feeling like your heart is racing. Urinary symptoms seem to be quite common in women specifically, but can also happen in men. So things like urgency, pain with urination. Obviously, loads of these symptoms are really vague and can be caused by loads of other illnesses. So it's really, really important that when you're looking into this, that all those other conditions are ruled out. So things like, if you've got gut symptoms, getting celiac disease ruled out, or inflammatory bowel disease, urine infections, things like that, other allergies, because MCAS can also look like allergies. So some of my patients, definitely not all, have anaphylaxis. So it's really important that actually the clinicians working with them are making sure it's not an allergy to a food, and that that's being thoroughly investigated.
So it's an anaphylaxis in the same kind of symptoms, but it would be from a trigger that's not necessarily like a known food allergen, do you mean?
Yes. So it's not
Mm.
necessarily an IgE response, which is what you get with a primary allergy. So it's not necessarily like that. And it's not always to the same food. So you can't say, well, every time I eat soya, I'm going to get anaphylaxis. It might be, it's a hot day and suddenly you eat a food that you're usually fine with, but you're also really stressed. And it's almost like that bucket's just gently filling up, and then suddenly it overflows, and people can get really severe symptoms, sometimes anaphylaxis. But you don't have to have anaphylaxis to have MCAS. Actually, the diagnosis can be really long-winded, because there's no clear-cut test that people can have that tells you definitely have MCAS. And there's no international consensus on actually what diagnostic criteria we should be following. So it's really, really tricky. You can test for some of those chemicals that those mast cells produce. So things like tryptase in your blood, or urinary prostaglandins or histamine, other chemicals that are produced. However, the urine tests are really expensive, so getting them done on the NHS is really difficult. Tryptase you would need to test at the time of a reaction and then at baseline. Arranging a blood test at the time you're having a reaction, unless you end up in A&E, is really, really tricky. So most doctors go on consensus 2, which basically talks about having symptoms in 2 or more body systems, and potentially a test of treatment, making sure everything else is ruled out. Because there are hundreds of chemicals produced by our mast cells, we can't test for all of them. Our tests aren't great. And that's a lot of people you're potentially missing out on if you're waiting for those tests to come back positive. And a lot of people struggle, without getting any answers.
Yeah, and it's hard with all those symptoms because they are so vague as well. They can easily be misdiagnosed as something else, like chronic UTIs or interstitial cystitis, without the proper investigations. And so
Yeah.
then people are left going down one rabbit hole, trying to resolve it, and actually it's something else altogether. So
Yeah.
frustrating for people.
It's really frustrating. And before my husband was diagnosed, he saw gastroenterologists, dermatologists, cardiologists, and they all said, well, we can't find anything. Everything's fine. And he was like, well, I'm not fine. I'm having all these horrible reactions. And he's a paramedic, so he had some knowledge. But for people that have no medical knowledge at all, this is a really scary condition, or can be, and can feel really isolating.
And not everyone has it to that extent that they get to that anaphylaxis stage, do they? Sometimes people will just have like low-lying chronic sort of irritating symptoms that are just, they're not quite right. It doesn't always escalate into something so dangerous, perhaps.
Not at all. So I would say the patients with anaphylaxis are generally the minority. So it's definitely not all patients. Sometimes you might have sort of MCAS underlying for many years, but have caused weird things to happen. So maybe you overreacted to like an insect bite, but you were okay, but you needed antihistamines and treatment, but it was more of an exaggerated response. Or you knew that you had more reactions around certain time in your menstrual cycles. And then sometimes it's an event in people's lives, like a virus, for example. Um, and I've seen this happen to more people during COVID as well, or people going through the perimenopause or the menopause, suddenly their hormones change and suddenly they find their reactions are getting worse, and it kind of unmasks the fact that maybe they've been dealing with it for many years, but actually now it's worse and they really need to deal with it. Um, so it can change and symptoms can change day to day. And that's why it's so tricky to sometimes track things and also to explain to health professionals actually what's going on in your body. Um, so it's really important to be able to communicate your symptoms in a way that almost makes sense or is orderly, because sometimes if you've got all these symptoms, it can be really, really difficult in a 10-minute appointment to unpack some of that. So if you are talking to a doctor about it, it can be really helpful to have maybe tracked things, keep like a food and symptom diary, or even a symptom and trigger diary, because it's not always food that triggers people with MCAS. Like I said, it can be anything in the environment. Um, so it's important to maybe track things like, are there certain times in your menstrual cycle that your reactions get worse? Um, is it stress? Is it temperature changes? Is it a combination of all of those things, which it absolutely can be. Um, I think a lot of people with MCAS turn to food because it's an easier thing to control. You can't shut yourself away from people wearing perfumes, or cleaning products or going outside, but you can sometimes control your food. However, it's not always food. I've got some people with MCAS that actually we've discovered food isn't their trigger at all. Um, and I see some really difficult things, like people getting down to 3 foods and then ending up really malnourished, and actually their MCAS gets worse because they're deficient in a whole range of nutrients. Their body's not getting enough energy, their body's not getting enough protein, so their body's in a chronic state of stress anyway. Um, and actually, if we can support these people earlier in the journey, we get much better outcomes and are able to try and prevent people getting down to 3 or 4 foods, which is really easy to do, unfortunately, because it just spirals.
Yeah, and especially if you don't know what the triggers are, it just feels safer for some people to not eat at all. Or, I work with quite a few people who say if I could stop eating and just take a pill, I would, because everything
Yeah.
feels so dangerous. I don't want to eat anymore. I don't enjoy it, and everything feels laced with danger. And when you put it like that, you can kind of understand, well, no, I can see why you don't. But then, like you're saying, it gets into that position of feeling quite malnourished because actually you aren't getting a broad range of nutrients anymore. Are there some sort of typical diet patterns that do help or make things worse? Like common, I mean, I know you said it's different for everyone, but are there any sort of common foods that people might be aware of that to look out for?
So there's no single diet for people with MCAS. It's a emerging condition. And what I mean by that is we don't have loads of research. We have one paper that looks at nutrition and MCAS and all of the research around it. We don't have good quality studies that compares the diet of people with MCAS compared to people that don't have it. But it's really important that we support people to identify their own food triggers. I don't have a single patient that has the same food trigger as another person. There's a lot of things online that talk about actually, you've got MCAS, you have to have a low histamine, low salicylate, low oxalate diet. That just isn't the case. And I think if we're starting there, that is the most restrictive option. And what I try and help patients with is actually having the least restrictive option, nutritionally, but also socially. But for some people, histamine does seem to be a trigger. So histamine in foods, like I say, not everybody, but foods high in histamine are really difficult to pin down. So online, there are hundreds of different lists. None of them say the same thing. So you could end up on a much more restrictive diet than you need to. There are studies that look at the histamine content in foods. Most of the research we have is in the last 10 years. So we don't have all of the answers. And even if we do have a list that is high histamine, low histamine, the histamine content of food depends on how it's stored, how it's transported, um, how it's packaged, lots of different factors. Um, but also you might not respond to it the same way on each day. So I have a lot of women that actually during the first half of their menstrual cycle can tolerate histamine containing foods absolutely fine. And then their estrogen peaks around ovulation and then about day 21. And that's when they struggle with higher histamine food. So reactions don't always look the same. Um, I think it's really important to remember as well that the low histamine diet isn't a long-term strategy. Um, it's meant as more of a way of being a detective basically and finding out what works for you. So I always describe it as doing a low histamine diet for 2 to 4 weeks and then reintroducing foods one by one to see if there are particular foods that trigger you, but also then we play around with, well, how much can you get away with? Can you cope with a little bit of histamine every day, or is it every other day? Um, but also teaching people how to balance it. So if they're super stressed, they might not want to push it with high histamine foods, or at certain times of the menstrual cycle, like I said. Um, so it's really teaching people to understand maybe when they're more likely to have a reaction, like post illness, for example. So in the couple of weeks after my husband gets ill, he has to be much stricter with his diet than when he's well, because of all the mast cell chemicals that are released during illness. He's also got a pollen allergy. So during pollen season, he has to be much stricter with the histamine that he eats compared to like Christmas when he can get away with bacon and higher histamine foods and it's okay. Um, but like I said, it's not just histamine for people with MCAS. There are other food triggers. So I usually start by doing like a food and symptom diary. So getting people to write down um, what they're eating, what their symptoms are. Um, and then we can kind of play detective that way, because there might be other food triggers that aren't histamine related.
And is it as well, you work though so that the histamine, it's like the bucket, you can eat certain foods on one day, but if you eat 3 of them all together, like you said, it's a really hot day, or maybe you're particularly stressed, you've had an argument with someone at work or something, and that it would set the scene for a reaction, whereas a bacon on another day would be actually fine. So it's not the same as like the FODMAP diet, where it's like you have a reaction to this particular food. It's more that it's like a tolerance to a condition, to the
Yeah,
conditions in which you eat it.
absolutely. And my husband's worst reactions have always been a perfect storm of a bit of all of what you just described. um,
It's
and
hard to find a list of actual histamine foods though. I did a bit of research for this into my book and actually trying to find relevant to date research that says this is how much histamine is in this particular food that's been replicated in another study to show, rather than just one person testing it one time. It's
yeah,
really hard. And there's so many lists that could just eliminate so many foods for people that they don't necessarily need to cut out.
yeah. The British Dietetic Association did work on a list last year, and is now out there. At the moment, you can only access it through working with a dietitian. It's not open access, which is why often patients do have to turn to lists online that aren't as accurate. Um, for example, there's one specific list that's online that talks about if you're low histamine, you have to avoid like all beans and pulses, all nuts. Whereas actually, when we've looked at the research, beans and pulses are low histamine, so are nuts. They're great sources of fiber in terms of supporting people's gut health. Um, if you are vegan or vegetarian, if you're suddenly doing a low histamine diet on your own, cutting out nuts, beans, and pulses, you're left with very little protein sources. So it's really important that you don't just do the diet on your own. It's really tempting, especially when you might not be able to access the support you need. But it can be dangerous. It can leave you open to nutritional deficiencies.
A lot of people I work with have already tried the low FODMAP diet, and then they layer in a low histamine diet on top of that, rather than saying, oh, FODMAP diet didn't work, I'm going to cut out more. And then they're cutting out all the fish and cheese and other things that they were getting. And it becomes, even more restrictive and quite trapping. Like think people feel quite paralyzed with it, because like you said, it feels like the only thing you can control. And so you want to have that like really strict control over it, because the symptoms are so bad, and it's like there's no, like I said, there's not much support as well. So I think that's the challenge, isn't it, of feeling trapped by the diet.
Absolutely. And sometimes it's not the actual food you're eating, it's the process of eating. So when we eat, we release histamine. We need it for stomach acid. But also just the process of eating can be, a challenge for someone's body that's already struggling. So often people go, well, I just can't eat, or I don't want to eat, let's cut more and more foods out. But actually, it's not always the answer. They need more support. And the way I describe MCAS is needing a little toolbox of things that can help you. And that might be medications, it might be supplements, it might be supporting your body to get the nutrition it needs, stress management, a bit of all of it. And in an ideal world, we would have multidisciplinary teams that can support these patients, because actually, a lot of people are resistant to us talking about, mental health around this. And I am never saying it's in your head. It's not. But what I am saying is it's a really difficult condition to manage. It takes over your life. It takes over everything. If you're experiencing, you might need a little bit of psychological support on the side. We need to work as a team. We need to look at nutrition, but we also need to be looking at what this is psychologically doing to you. And if you're terrified of food, me just telling you to go and eat that food isn't going to cut it. We need to be supporting every aspect of someone's health.
What sort of support is there, like medically? Can people take anything, or what can the doctors do if you do get a positive diagnosis from a doctor?
There is a brilliant sheet by Mast Cell Action, the charity that supports those with MCAS in the UK, that's written by doctors for your GP. And it talks about what MCAS is, what it looks like, what GPs can do to help. And it lists all the medication that can be used in primary care. So things like H1 and H2 antihistamines, because you have different histamine receptors throughout your body. Also things like mast cell stabilizers, so ketotifan's one people often see. There's things like sodium chromoglycate, which can sometimes be used to target those mast cell related gut symptoms. So there are lots of things that can be done. Some can be done through the GP. Unfortunately, at the moment, there's no good place in the NHS that MCAS sits. So a lot of allergy services aren't commissioned to take on MCAS patients. So a lot of the immunology and allergy referrers are declined, and it's on the GP to manage it. Some of the medications are available through the GP. However, some medications are listed that they can only be prescribed through a secondary care, so a hospital consultant. So that's where it can be really difficult if those mast cell stabilizing medications, actually your GP's hands are tied, they can't prescribe them. And then there's nowhere they can refer you on to. Sometimes it falls to being referred to a specific consultant for specific symptoms. So there are, MCAS aware gastroenterologists, for example, or respiratory consultants, and they can prescribe medications that might help. If you have MCAS, you can also react to medications. So sometimes it takes a lot of trial and error by the doctors to try and find something that works and that helps and that you can tolerate.
That's really interesting. I was speaking to someone last week on the podcast about connective tissue disorders and hypermobility, and she was saying the same thing, that actually there's no one home for this in the NHS that looks at all connective tissue disorders and hypermobility and how it affects your whole body rather than just the gut or just your joints or something. So yeah, kind of similar position really, where it's falling through some gaps and people are not getting the specialist help they need because they just get their silo help from the consultant.
Yeah, and we think there are overlapping conditions. So there's a new charity called the Overlapping Illness Alliance, and it has representatives from each charity, like POTS UK and Mast Cell Action, EDS UK, because actually some of these illnesses seem to overlap. There seems to be an increased risk of MCAS with things like hypermobility and connective tissue disorders, and POTS as well. Most of my patients' MCAS rarely comes alone. It comes with friends, unfortunately, and then you have to manage all of the other conditions that it comes with as well.
I know you mentioned about perimenopause, and just while we were talking about like other things that can happen. So when people might start to take HRT, because it's, sort of estrogen can be triggered, do you find that it's quite difficult for people to get hormonal replacement at perimenopause if they've got MCAS?
So is it difficult for them to be able to
For them,
accept the
yeah, to take
HRT?
like synthetic estrogen, does it typically make things worse by adding estrogen back in?
Can be a really real mix. So we think that estrogen potentially activates mast cells, and progesterone might help to stabilize them. So progesterone is the first thing to decrease during the perimenopause. That can almost take the brakes off the mast cells, and then things go crazy. And then you have these huge peaks of estrogen during the perimenopause, which can push the histamine up and activate the mast cells more. However, saying that, perimenopause symptoms can look really similar to mast cell activation syndrome. So not everyone experiencing these symptoms definitely has MCAS. Some people need the estrogen though. So you can't just say, oh, they've got MCAS, you know, don't do HRT, but it takes doctors that understand MCAS and understand histamine to be able to titrate HRT in a more specialist way. And they might go in with another hormone first before they go in with estrogen, or they might go in with tiny doses, lots of different ways. But I've got patients that, do have MCAS and are on HRT. But I wouldn't say it's always a straight road, but it probably isn't for any woman, even if you don't have MCAS.
Yeah, still a bit of trial and error, isn't it? Yeah. Okay. Yeah. All right. That's good. And then what are the other sort of things that people might look out for? Like if they were, you mentioned at the very beginning, like a whole collection of symptoms, it can be difficult. But if people just feeling not right, they've got, most of the people who listen to this have got digestive issues, but there's an overlap, like you said, with many conditions. So how would people sort of first get their thoughts, or maybe this is MCAS, like are there any sort of real key signifiers that you would advise people to look for?
So I would look, if you don't just have digestive symptoms, if you have bloating and diarrhea, it's significant. It can take over your life, but I wouldn't automatically be thinking MCAS. But if your gut symptoms maybe come with other system symptoms, so things like rashes or cardiovascular symptoms, or you just feel like you've been run over by a bus, so brain fog, fatigue, you might want to start that conversation. I wouldn't go to the doctor and say, I have MCAS, but you might want to open up saying, I've got all these symptoms in different parts of my body. I've read about MCAS. Do you think that's something we could look into? So making it more of a collaborative approach rather than this is what I've got, I've seen it on Instagram. Um, and then hopefully the doctor will be more open to looking at that with you. Because like I said, it's so important to rule out other conditions. You absolutely might have these symptoms in every single part of your body, but although it might feel like a longer road for you, it is important other things are ruled out.
And you can have digestive conditions, and you could have, I don't know, atrial fibrillation, and you could have
Yeah.
psoriasis or something. Those can be three separate conditions, but actually that may be explainable by different conditions, or they may be symptoms of something wider, which is
Yeah.
what's really tricky, isn't it?
Yeah, really tricky. And it's not something the doctor's going to be able to answer in one appointment. You probably are going to have multiple appointments. And that can be really frustrating for people because we naturally, as humans, want answers straight away. I absolutely do. but
Yeah.
unfortunately, sometimes this takes a lot of unpicking.
Yes, and it's hard to have the patience when you don't, I mean, like, calm patience rather,
Yeah,
to feel like you want to go through all these testing processes, testing foods, testing medication. Like it's so draining and challenging for people to take those steps and to feel like you want to keep going and pushing on with all these different trials in order, yeah, each one is
absolutely. And people have
frightening.
lives. Like, I would say you can get MCAS at any age, but the majority of my patients are in midlife, and midlife is busy. You're often like looking after children or elderly relatives and um, trying to work at the same time. And then we're telling you to, go and try out food. Well, actually, how can they risk feeling that unwell when they've got other life responsibilities? It can be really difficult. And unfortunately, there are a group of patients that are really very unwell and bedbound or can't leave the house. And, um, they might not be able to prepare their own food and they're relying on other people who might be busy and um, saying to, well, go and try this food. Actually, they're terrified of reaction maybe when they're in the house on their own. So you've got to think about all these practicalities of what we're asking people to do.
Yeah, it's hard to keep pushing and also takes, such baby steps sometimes. But I think, yeah, working with a specialist, sorry, like you, who can keep encouraging them and know when to keep pushing and actually when it's, okay, maybe you have had enough, maybe this is time to back off this trial or whatever, and
Yeah.
when to keep pushing.
And sometimes if people have been off of food a very long time, I do find that their bodies can have become more sensitive to it, which is why I'm really keen to try and keep as many foods in the first place. So if that has been the case and someone has been off foods for, a long time, then we might talk about going in really slowly. And by that, I'm talking about like having a bite of something one day, see how you are, leave it a day, and then you can either stick at the same portion or just gradually titrate up over a week or a couple of weeks to try and get that food in. Um, and for people that are really scared of the food as well because of the experiences they had, that can um, help their nervous system feel a bit calmer as well. So, um, really gradually going in. But also, if people are scared of food, often talk about things like um, doing box breathing or diaphragmatic breathing if you can before meals, or if that doesn't work for you, then anything you enjoy, like listening to music or anything that's going to kind of relax you before you try the food, because symptoms of panic um, and fear and fight or flight can look really similar to an MCAS or an allergic type reaction.
Yeah, so actually some of those like adrenaline or cortisol's like driving the symptoms as well as what you're
Yeah.
doing.
Yeah.
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 And
So
what and
sometimes you can
what's
start really slowly.
sorry, I was going
Sorry.
to say, what's your experience of how much microbes in the gut might interact with the histamine production process or, the gut microbiome and MCAS?
So in terms of MCAS, we have nothing on how the microbiome might look. However, in histamine intolerance, so histamine intolerance is different. So we think histamine intolerance is caused by a reduction in how our body breaks down histamine through the enzyme called diamine oxidase. Um, so we have more research in how gut bacteria changes might look like in histamine intolerance, and we think that people who have histamine intolerance gut bacteria might look different. Um, there are gut bacteria that produce histamine. There are gut bacteria that might help us break it down. So the balance of that probably does matter. Um, I have seen patients who develop histamine intolerance as a result of things that affect their gut, so things like antibiotics or gastrointestinal illnesses. So I do think that the microbiome matters in histamine intolerance. I suspect it probably does in MCAS, but we just don't have the data to back it up. I think I wonder whether it plays a role when people's diets become so narrow and they're on 3 or 4 foods. And does that that's going to change your microbiome, that restricted diet. So does that make it more difficult to get foods in? I would love the research to tell us. You've got loads of mast cells that produce histamine and loads of other chemicals in your gut. So it's a complex communication network between your gut bacteria and your body. Um, so there is some limited evidence that fiber can help stabilize mast cells, and the fiber that you eat is broken down by your gut bacteria, can produce anti-inflammatory chemicals like butyrate. That's going to have a positive impact, MCAS or otherwise. So I do try and encourage patients with MCAS to try and eat as much fiber as is possible for them. Obviously, if they're on a diet that has no fiber in, we're not going to suddenly go eat all these fibrous foods, because actually they're going to get more gut symptoms. But if we can gradually increase the amount of fiber that they're eating and support their gut health alongside the MCAS, we're not doing any harm. It's a positive thing. So in the lack of research, I think it's an appropriate thing to do to encourage them to have a healthy, balanced diet if we can get it in. And it might be that they can never have every single plant-based food that we want them to, but can we get enough fiber in through the limited foods that they might have? So simple answer, I think gut bacteria probably does play a role, but we just don't know enough about it yet.
What about SIBO, so up in the small intestine? Because that's another condition where there's limited research and some sort of misinformation as well about, what it is and how to treat it. But it's another area, I think, where people get, an overlap of symptoms, perhaps. What's your experience?
Yeah, so small intestinal bacterial overgrowth is a condition where we want most of your gut bacteria to be in your large bowel. We don't really want it to overgrow in your small intestine, whereas sometimes that happens. So there are things that can increase that risk of being on long-term proton pump inhibitors like omeprazole, lansoprazole, or having certain types of surgery, potentially connective tissue disorders like hypermobile Ehlers-Danlos Syndrome. So SIBO is something we do see in patients with MCAS, and we do think that SIBO activates the immune system. So there does seem to be a crossover. There was one study in America that shows that there was potentially an increased risk of SIBO with MCAS. But again, we don't have all the answers, but it's something we see. The gold standard treatment for SIBO is antibiotics, usually one called rifaximin. Sometimes when the SIBO is treated, I have seen, people be able to accept more foods, be able to tolerate more foods. Sometimes the MCAS is calmer, but as I said, people with MCAS can react to any medication. Sometimes that doesn't happen, and sometimes people can react to the antibiotics that are being given for the SIBO. So it's not always clear cut, but it does seem to be part of some people's pictures. It is something that often doctors that work in MCAS do test for. But I think it's important to remember that not everyone with gut symptoms is going to have SIBO. The testing that we have, which are breath tests, are not 100% accurate. There can be false positives and false negatives. And actually the guidelines for like IBS diarrhea, for example, suggests that if there is a higher risk of SIBO for patients like long-term PPIs, that actually they don't test for it. They do a trial of treatment. So gastroenterologists aren't going to be suggesting testing for SIBO for every single patient that has gut symptoms and potentially has MCAS. So it's complex, but it might be part of some people's picture.
Thank you. That's really helpful. Great. Is there anything else you would like to sort of leave people with, or, people who either know they've got it or are worried about it, or,
Yeah. So I think the main thing is don't over restrict your diet without any support. So it's really important not to self-diagnose with these things and say, well, I need to cut out all the food. You absolutely don't. Actually, it's really important to support your body with adequate nutrition whilst you're going through these really, really difficult symptoms. please reach out for support, even if the professional isn't aware of these conditions. They can support you with initial tests, actually ruling out other things. And a lot of professionals aren't necessarily dismissive of these conditions. It's just we don't know enough about them. There's no UK guidelines for how we should manage them. Um, so most professionals do want to help you, do want to do research on the condition. I've had GPs go away and not know about MCAS and go away and do loads of research. I acknowledge not every health professional has time to do that, but don't just assume that because this is a new and known condition that you are going to be dismissed. It does happen, but I think it's really important to go in there with a positive mindset and an open mind, so that people can help you. Um, it's important that nutrition deficiencies are ruled out. So things like low iron. There's some research that low iron can potentially activate mast cells, so can add to that problem. A problem I see in so many women, and women that might have been told their iron levels were perfectly fine, but actually the NICE guidance, the guidance that we should be following, changed last year, and it's a higher cutoff now than it was before. So women that were told their ferritin levels of their iron stores were normal before, they wouldn't be told that now, hopefully. So it's important that actually, if you are, really tired or dizzy, that actually we look at iron, B12, folate, we're looking at nutrients as well. So there's so much to unpick, but the key thing is we need to nutritionally support your body. We don't need to be cutting out hundreds of foods from the starting point. If you're getting to that point through no fault of your own, you are down to 3 foods, make sure you get support, because actually we need to make sure you are not malnourished. Thank you.
Yeah. And where can people find you if they want to look you up?
Yeah, so I'm at thecalmgutdietitian.com. I'm on Instagram as Calm Gut Dietitian. I'm also on the Dietetic Advisory Panel for Mast Cell Action, the charity that supports those with MCAS. We do loads of free webinars that talk about diet and MCAS. There's loads of other things through Mast Cell Action, like mindfulness, chair Pilates, like loads of activities they provide that patients can access, and a wealth of information. They've got a medical advisory board where you can get sound evidence-based information.
Thank you so much for today. That was brilliant. Thank you.
Thanks so much for having me.
That was a great episode. If you want more support on histamine intolerance in particular, I do have a chapter in my book dedicated to histamine intolerance and how to tackle this from a dietary perspective. As Chloe says, histamine intolerance is one potential presentation of all of these symptoms. But if it's something you're interested in exploring a little bit, then you can find my book, which is called Inside Knowledge for People with IBS and SIBO, on Amazon. And you can download it as a Kindle version, but also it's available as a paperback. In there, you'll find out what is the low histamine diet, how to tackle it, and my list of high histamine foods that I've done extensive research on to gather the best data. So do go and follow Chloe at the Calm Gut Dietitian, and please share this episode with someone who's got MCAS or SIBO and may find this helpful, because this is the only way we're going to get the word out from it, is by sharing real evidence-based information about what MCAS is, what histamine intolerance is and isn't, and how people might be able to identify whether they've got it or not. Okay, I'm going to leave it there for this week. Thanks so much for listening to this episode of the Inside Knowledge Better Digestion for Everyone.